Okay, so ocular manifestations of systemic disease, what does that mean? That means you've got a systemic disease with the prime example being diabetes, where it can affect the eye. So there's a few of these that you definitely need to know about. And the concern with some of these conditions is they don't always cause symptoms in the early stages. So you need to be aware of them and be referring people to ophthalmology, potentially, for early screening and detection so that the person's not turning up by the time they've got visual loss, right? So that's why they're important. So systemic diseases can cause eye signs, and someone presenting with an eye sign, or a visual problem might have an underlying systemic disease. So it's a two-way road, okay? What we'll do today, I'll give you a brief overview, then we'll talk about the conditions that I want you to know about, and then we'll have a little summary at the end. The main conditions are diabetes, hypertensive retinopathy, so, garden variety hypertension, then thyroid eye disease, then there's some infections which occur in people who are immunosuppressed, and there's lots of drugs which can cause eye toxicity. So that's the group that I need you guys to know. What are our learning objectives? Well, to understand the systemic conditions and medications that I just mentioned, to be able to diagnose and manage those conditions appropriately in patients who are immunosuppressed, to know who needs ocular screening and when. And finally, I've picked 4 medications with ocular. There's many more, but these are the 4 that are the most common out there in the community and in the hospital setting that you really need to know about. So they're hydroxychloroquine. The trade name for that is Plaquenil. And there's, again, garden variety steroids, prednisolone. Then there's tamsulosin, which is used for benign prostatic hypertrophy, prostate disease, and amioderone. So we'll get to those. I want to start off with your curriculum. So there's common eye problems and serious eye problems and some that are in the middle. So what we'll be talking about today is diabetic retinopathy, which is both thyroid eye disease or thyroid-associated orbitopathy, which is a potentially serious condition. Drug toxicity, potentially serious, not necessarily common. And uveitis. Uveitis is the umbrella term for inflammation in the eye, right? So today, the uveitis that we'll be talking about are the opportunistic infections that happen in immunosuppressed people. Okay, if you want to look at ocular manifestations of systemic disease, there are whole books written about this. Here's a whole book that just talks about this issue, right? Obviously, we don't have time to cover that, nor do you need to know the whole book. That's my job. So we're going to limit our discussion to a few conditions today. What you do need to think about is your normal surgical sieve. So like with any medical condition, you want to think, well, what's the underlying etiology here, right, of this eye condition? So as I say, there's dozens of these, and many are asymptomatic. So you need to be aware of them. And today we're going to talk about the common ocular manifestations of the more common systemic diseases. The most common etiology tends to be vascular, as in, how do systemic diseases affect the eye? Most commonly it's through vascular supply. Immune response plays a role. Inflammatory response definitely is also another common denominator, but mainly it's through blood spread. You can get direct anatomical spread as well. So if I've got an infection in my in my sinus, if I've got infectious sinusitis, that can become an orbital infection or an eye infection. So that's direct spread, but most commonly it's through vascular. So what are the examples? Well, hypoglycemia leads to microvascular damage to blood vessels within the eye. That's what causes diabetic retinopathy. Bugs floating around, in a septic person are what lead to infection of the retina or the choroid, okay, the back of the eye. Medications, similarly, systemic circulation deposits them in ocular tissues. Then you've got systemic issues where there's a nutritional deficiency, which can lead to some eye problems, vitamin A deficiency, for example. Methanol is often contained in homemade alcohol, okay? And where this becomes a risk is when people are traveling overseas, often Southeast Asia, let's say, where there's sort of, bootleg alcohol being sold in a little pop-up bar. So as an example, I remember seeing a patient at Royal Perth when I was a registrar. It's a 22-year-old guy, young guy. He was a plumber, lovely guy, went to Bali with his friends, as you do, got drunk, and it turned out that he drank local-made brew, bootleg alcohol. So methanol toxicity causes blindness, okay? So this young 22-year-old guy potentially was going to be legally blind. He definitely lost a lot of vision. Tragic incident. So if you go to Southeast Asia, beware. Don't drink bootleg alcohol, but it's just an example of, a systemic event that causes visual loss. Immune response is what happens in thyroid eye disease and in the infectious causes. More broadly, the eye is the only organ where we can directly visualize, non-invasively visualize blood vessels, non-invasively directly visualize a nerve. The optic nerve is an extension of the brain, right? It's a second cranial nerve. So it gives you a lot of information just on examination. And ophthalmology is very heavily examination oriented, the more you do it. Diabetes is paramount. So if there's one thing I want you to take away from this is that every diabetic needs to have their eyes screened at least once every 2 years, if not every year. And I can tell you that this still isn't commonly enough understood out there in the community, because I've got a family member who developed gestational diabetes, and they only had their eyes checked when I asked them if they'd had their eyes checked. The GP hadn't referred them, obstetrician hadn't referred them. So people aren't thinking about this enough. Diabetes is crazy common. You guys know that. It's going to become more common. So just drill that into your memory, that every single diabetic, it's not just glycemic control, it's not just kidneys, it's not just peripheral neuropathy, it's eyes as well. Okay, minimum of once every 2 years, if not every year. So what's the safe approach overall? Someone presents with eye signs or symptoms, just think, could there be an underlying systemic disease? Do they have diabetes, first and foremost? And secondly, in someone with a systemic diagnosis or medication, particularly if they're the ones we cover today, you need to think, could this cause eye problems? That's the overview. So let's now get into the core conditions. There's a normal fundus. That's a patient's left eye. How do I know it's a left eye? This is how. When you see a photograph of the fundus, right, the back of the eye, patient's always looking at you. Patient's always looking at you. When the patient's looking at you, the optic nerve, which is the round yellow disc, okay, that's the optic nerve, that's always closer to the nose. So it's on the nasal side of the eye. So if the patient's looking at you and the midline is to the left of this photo from where you're looking, to the left, right, that's where the nose is, so that's the midline. This is the patient's left eye. And so the right fundus would be over here where my left hand is. So the nerve is nasal. So remember that. When we do exams and we show you a fundus photo, often we'll ask, is this the right eye or the left eye? It's a very easy point to score in your exams, but also in real life. There may well come a time, some GP practices are doing this already, where they do fundus screening inside the GP practice with a camera, with a fundus camera. Then you can quickly comment left eye, right eye. So the nerve is nasal, remember that. This is a normal fundus, and quite easily you can see that this is an abnormal fundus. So again, in an OSCE setting, first thing I want you to say is, this is a fundus photo of the patient's left eye. It's clearly abnormal. Then I'll go, what's the main abnormality? You'll say, well, there's red dots in areas where I'm not used to seeing them in a normal fundus. You don't have to get fancy. If you just say that, I know that you see what I'm seeing, right? What are those red dots? It's blood. We call those intraretinal hemorrhages, blood within the retina, intraretinal hemorrhages. Intraretinal hemorrhages happen in several diseases, but probably the most common one is diabetic retinopathy. Because as I said earlier, you get microvascular damage So blood vessels that should be watertight become leaky and leak blood into the surrounding retinal tissue. So that's the first abnormality in this photo. There's several. I'm just going to mention two. One is the blood. The second one are those bright yellow dots that you see lateral to the macula. The macula is a sort of dark center of the fundus. So those bright yellow dots shouldn't be there. They're not there in the normal fundus photo. So they're what we call hard exudates. Hard exudates. And hard exudates are deposits of lipid. Okay, lipid within the retina. So just like, when blood vessels leak, they don't just leak blood. They also, blood contains lipid. So that can get deposited within the retina, and that's what hard exudates are. Again, typical in diabetic retinopathy, leaky blood vessels. So the preamble to this photo, let's say again, an anoscopy would have been, here's a 55-year-old diabetic, and immediately you're thinking, ooh, could be diabetic retinopathy. You see the photo, yes, linked as a diagnosis. Then we talk about management. There's a whole talk on diabetic retinopathy on the YouTube channel. Okay, that's the thumbnail for it. I won't go too much more into detail for that reason. So please, that's a mandatory part of your curriculum. So make sure you've watched that. This is just showing you, I think this is a good slide for showing you the progression in severity of diabetic retinopathy. So it goes from no visible disease to mild to moderate to severe, and then PDR means proliferative diabetic retinopathy. Again, I won't go too much more into this, but the aim of management at the primary care level, let's say, GP, hospital doctor, is to prevent people getting to definitely to PDR, but even to severe or moderate. So they need to be screened and diagnosed early. Okay, next condition. The diagnosis is up the top, hypertensive retinopathy. What are the signs that we're interested in here? In some ways, it's similar to diabetic retinopathy, okay? But the earliest and probably most important sign in hypertensive retinopathy is that the retinal arteries, here's an example, become attenuated. Attenuated means thinned or reduced. So if you look at this inferior artery down here, and then compare it with this artery up here. I think you'll agree that the superior artery looks a lot thinner than the inferior one. So that's attenuation of the whole artery. But artery can also become attenuated or thinned. This actually doesn't show it that well, I don't think, but it can become thinned in segments. So you can get focal thinning, or you can get overall thinning. And that's probably the earliest sign of hypertensive retinopathy. You probably need to see a few fundus photos to recognize a thin artery from a normal artery. But even within the one fundus photo, you can see how different arteries have different calibers, different diameters. How can you tell an artery apart from a vein? Well, veins are higher caliber than arteries in general. So this is a vein, and this is a vein, right? So they're thicker and they're darker because it's venous blood, right? That's how you differentiate veins from arteries. If we go back to the normal fundus photo, that's a vein, right? Thicker and darker. That's a vein, thicker and darker. These are arteries. They're about 2/3 the diameter of a vein, and they're not as dark red. So that's how you differentiate. And both veins and arteries come off the optic disc to supply the retina. So you've got arterial thinning, but you've also got these white fluffy patches. We call those cotton wool spots because they look like cotton wool. Cotton wool spots represent an infarction of the inner retina, okay? So in hypertensive retinopathy, a bit like diabetic retinopathy, blood supply to the retina gets reduced from this arteriolar narrowing or attenuation. So you get little focal areas of ischemia, necrosis, and infarction. That's what those cotton wool spots are. So they're just two of the signs to look for. But I'm going to show you a few more now. This represents what we call arteriovenous nicking. It's also mentioned in this image somewhere, I think. Here we go, arteriovenous changes. Look, arteries generally travel over the top of veins, But in hypertensive retinopathy, because you get sclerosis of the artery, right, hardening of the artery, it can pinch and somewhat squash the underlying vein. So if you compare the diameter of the vein there, right next to where the artery crosses it, to the diameter of the vein there, I think you'll agree the diameter here, it looks squashed. It looks thinned and squashed. So the artery is squashing the underlying vein. This becomes a risk factor for blocking off this vein altogether, right? Which is called a retinal vein occlusion. So systemic hypertension leads to arteriovenous nicking, which is what this is. And arteriovenous nicking is a risk factor for retinal vein occlusions. Retinal vein occlusions are also quite common, right? So that's a key sign in hypertensive retinopathy. This, so here's cotton wool spots again, and copper wiring and then silver wiring, they're sort of later signs of hypertensive retinopathy where the color of the blood vessels, instead of being red, starts to become paler and paler. And that's caused by sclerosis. So copper wiring is more pale than usual. Silver wiring, as the name suggests, very pale. So they're late signs in hypertensive retinopathy. But also, more importantly, this person's got swollen optic discs. And if both optic discs are swollen, we call that papilledema. Papilledema is swelling of both optic discs, often asymmetric. This person's is asymmetric. Left optic disc is more swollen than the right optic disc. Papilledema is a brain tumor until proven otherwise, right? Because in a brain tumor, intracranial pressure goes up, which leads to an increased pressure in the subarachnoid space, leads to swelling of the optic discs, right? But most papilledema is not a brain tumor. That's just the life-threatening thing, which you have to exclude. The first thing you do when you see someone with papilledema, and we've got a whole lecture on this online, so I won't go into too much detail, but the first thing you need to do is measure the blood pressure, because malignant hypertension, very bad hypertension, systolic over 200, diastolic over 100, also causes papilledema. So you can save them a whole bunch of unnecessary tests. You can save them a lumbar puncture, basically, if you just check the bedside blood pressure, okay? So malignant hypertension as a cause of papilledema. This image in your top left, so this is called an OCT scan. It's a scan of the back of the eye that we do every day. And the red and the white areas here represent swelling of the retina, So this bit's swollen, that's the macula, this bit's swollen. The retina can become swollen in very bad hypertensive retinopathy for the same reason that it does in diabetic retinopathy, because the blood vessels become leaky. So instead of being watertight, they become leaky. So you get swelling at the back of the eye. That causes visual impairment. So you can imagine if your macula is swollen, the macula is what provides good central vision. We're all looking at each other using our macula. If it's swollen, you're not going to be able to see clearly. You won't see people's faces and this sort of thing. This is a cross-section, this image here, of this swelling. So this lumpy, bumpy appearance, that shouldn't be there. That's fluid underneath the retina. So very advanced hypertensive retinopathy can cause not only optic nerve swelling, but swelling of the macula as well, okay? So let's quickly go through more or less everything I've just said. What's the etiology here? Well, it's arteriosclerosis from either from sustained long-term systemic hypertension or from acute and suddenly very, very high blood pressure, which can ultimately lead to exudation, as I say, exudation, leakage of fluid from a disrupted blood-retinal barrier. That's what BRB is, blood-retinal barrier. So normally there's a barrier that separates retinal blood vessels, as I've said, from leaking, a bit like the blood-brain barrier. So as a result, that gets disrupted and you get leakage of blood and plasma. How do people present? Well, if it's bad enough, they present with blurred vision, but it can certainly be asymptomatic. Malignant hypertension can cause headaches. They might also present with known hypertension, cardiovascular disease, ischemic heart disease, peripheral vascular disease, all the vasculopathic type chronic disease that is common in the community. And the signs I've listed there, it's all the stuff that we talked about when we were looking at the images. CWS is cotton wool spots, arteriovenous nicking, retinal hemorrhages, and so on. We grade hypertensive retinopathy. This is sort of, extra points in the OSCE level. You don't need this to pass, but how we grade it is when you've only got those arterial changes, that's down the mild end. By the time you've got swelling of the optic disc, that's severe, and everything else is in between. So if it's just blood vessels, the arteries don't look normal, that's mild. Swollen optic discs, severe. If you've got blood, if you've got cotton wool spots, that's somewhere in between, okay? What's the differentials here? Well, this is vascular disease of the retina, so your main differential is always going to be diabetes. So you need to tease those apart. Is the person diabetic? That's the first question you need to ask. Retinal vein occlusion I mentioned. Retinal vein occlusion tends to be unilateral, whereas hypertensive and diabetic retinopathy are both bilateral. Anemia can be bilateral as well, so you also need to ask about anemia can cause similar signs. What's the management here? Well, if you've got severe retinopathy, then you need to reduce the blood pressure quickly, but not too quickly, okay? Because this is a retina that's become dependent on high blood pressure for its oxygen delivery. So 10 to 15% in the first hour, no more than 25% in the first day. And then ultimately you want to aim for your normal sort of guidelines. If they've got a hypertensive crisis, okay, malignant hypertension, then obviously they're going to ED. And the prognosis, well, the risk here is of retinal vein occlusions, RVO, that's what that is, retinal vein occlusion. RAO is retinal artery occlusion, so occlusion of arteries and veins, but also optic neuropathy, damage to the optic nerve, macular detachment, which is really what that picture is, the fluid under the macula, so the macula's become detached, worsening of diabetic retinopathy, DR. So if you've got diabetic retinopathy and you've got hypertension, the whole thing gets worse. And then you've got your systemic risks as well. Cerebrovascular disease, CVD, ischemic heart disease, peripheral vascular disease, and so on. So there's ocular concerns and systemic concerns. Okay, so that's hypertensive retinopathy. How are we going for time? Running behind as usual. That's okay. So here's just some cartoon images basically of hypertensive retinopathy getting worse. And you can see how as it gets worse, the vessels become paler. So that's normal vessels progressing to copper wiring, progressing to silver wiring at the end as they become more and more sclerosed. Anyone know this guy? I've seen him, you're too young. Rodney Dangerfield, he was an American comedian. And his eyes were kind of part of his act because he'd always look stunned or surprised. But this guy had thyroid eye disease, okay? So thyroid eye disease is the most common cause of proptosis. Proptosis means bulging eyes or prominent eyes. And in thyroid eye disease, the eyes are pushed forward within the eye socket. So they actually are pushing outwards more than the average eye, and the eyelids are left behind. So the eyelids stay where they are, but the eye is more forward. So it looks like the eyelids are raised, but they're not really raised. It's just that the eye itself has been pushed forward. The eye gets pushed forward because the tissue within the eye socket swells and expands. So the muscles surrounding the eye and the fat within the eye socket, because of an immune response, swells and expands, pushes the eye forward, and you get this proptosis appearance. Here's another example. And you can see that this person not only has, really prominent eyes, they've got proptosis, but the eyes also look red, right? Conjunctival injection is what we call that. The conjunctiva looks red. This person looks like they'd be quite uncomfortable. And so this is acute thyroid eye disease. And thyroid eye disease, or thyroid-associated orbitopathy, which is what it's called these days, can have an acute phase where there's a lot of swelling happening acutely, making the front surface of the eye quite uncomfortable because you just can't close the eyelids over the top of the eye. Right? It's been pushed that far forward. When you can't close your eyelids, the surface of the eye becomes dry because it's exposed to the air, right? You don't have that constant blinking, which is refreshing the tears over the surface. So they get painful dry eyes, these guys, and you need to manage the painful dry eye. Here's someone with not acute thyroid eye disease, but with chronic stable thyroid eye disease, which is not symmetric. So the left eye is proptose, the right eye isn't, their left eye. That's why the left eye looks more prominent, right? So you could confuse this for other things. You could think, oh, they've got a ptosis in the right upper lid. The right upper lid's down. Maybe it's a third nerve palsy. Maybe it's a Horner syndrome. They're not bad thoughts, but you'll see the pupil sizes are symmetric. There's no difference between the right and left pupil. And if this was an OSCE question or in real life, you need to ask about a history of thyroid abnormality, hyperthyroidism, right? So it just shows that, yeah, yes, it's bilateral, but it can definitely be asymmetric. The MRI image up top shows swelling. So these are the muscles that supply eye movements. This is the lateral rectus, right? This is more normal. Have a look at this lateral rectus. See how enlarged the muscle belly is? This is massively enlarged. This is the medial rectus, same here. So this is the first thing that happens in thyroid orbitopathy, is that the muscles swell and there's only so much volume there in the eye socket, so therefore everything gets pushed forwards. This image here is someone who had stable thyroid eye disease, who then had what we call orbital decompression surgery, where you can literally fracture the orbital floor, create more volume within the orbit, get rid of some of the soft tissue. And this is life-changing surgery for patients. You know, aesthetically, you know, you walk around your whole life with these big bulging eyes and then you have an operation and you look like everyone else. So this can become an option once the thyroid eye disease is stable and if people are left with very bad proptosis. But let's go through it from the beginning. What's the etiology here? It's autoimmune. You get orbital fibroblasts, which are activated by autoantibodies against thyroid receptors. And so you get enlargement of that soft tissue, as I've said. It's mainly hyperthyroid, but it is often completely independent of systemic activity. So you can have hot thyroid orbitopathy, acute inflamed, but your thyroid levels are currently normal. They're not necessarily linked, but of course you want to optimize their thyroid function. Smoking is probably the main modifiable risk factor. So all these guys, you need to ask them if they smoke. So what's the presentation? Bulging eyes, discomfort, redness, as we've said. When it's really bad, though, they can get diplopia. Because if your muscles, so double vision, if your muscles become swollen enough, they can't turn the eye properly. So you can have one eye looking out here, the other eye looking in different direction, and then you got two images, which is what causes double vision, right? Eyes looking in different directions. Lid retraction is this effect where the lid looks raised and you can see all this white sclera above the colored iris. You don't normally see this sclera. If you look at the person next to you, you're not going to see the top of their sclera, right? Restricted extraocular movements, EOM, causing the diplopia. Lag ophthalmos is the inability to close the eyes completely. So if you get a patient with thyroid eye disease, just ask them to gently try and close their eye. Don't force close them. Gently close them. And if there's a little gap, even if it's 0.5 millimeter or 1 millimeter, that's bad enough to dry the eye out, especially overnight. So they wake up with really uncomfortable eyes. If it's bad enough, ultimately you can squash the optic nerve. and get an optic neuropathy. So again, remember, there's a limited amount of, there's only so much volume in the eye socket. If you keep increasing the contents, something's going to get squashed. And the optic nerve is at risk ultimately of getting squashed. So think of thyroid eye disease as someone's got to manage the front of the eye, the surface that's getting dry, and someone's got to be aware of what's happening with the optic nerve, because we don't want to squash it and extinguish it, because then you lose vision. Okay. What's the differential here with bilateral orbital tumors? Pretty rare, but it can happen. So tumors in both eye sockets. And a carotid cavernous fistula can do it. A fistula between the carotid system and the cavernous sinus within the brain. And that often happens in motor vehicle accident setting. So you get a traumatic carotid cavernous fistula. Can be unilateral, can be bilateral. Someone's had a car accident, they look like they're proptosed. That's bad news. Right? They need urgent CT or MRI. What's the management here? Primary care in acute thyroid orbitopathy, bog standard, oral non-steroidals, salt restriction, okay, because that makes swelling and inflammation worse. Quit smoking is the most important one, as I said, and then thyroid management with an endocrinologist. In the acute phase, they need steroids, right? After they've had some imaging to establish a diagnosis, high-dose steroids. These days, we tend to admit them and give them IV steroids over 3 days with a tapering course of steroids after that. And eventually, they need to be on steroid-sparing agents. You don't want them on steroids forever. So biologic medications. And as I say, we manage the cornea. Radiotherapy, in theory, you can do to reduce the volume of the orbital contents. It's probably out, happens less commonly now. And then in the stable phase, as I said, you can have lid surgery to lower the lids if you need to, extraocular muscle surgery, if the muscles aren't in the right position, and then orbital decompression, which is what this lady's had. Prognosis, if they're caught and treated early with steroids, let's say in acute, generally quite good. Yeah. But just something to be aware of in your hyperthyroid patients. Get them seen at least once by an ophthalmologist, so they're known to an ophthalmologist in case they become acute. Okay. Okay, here's a fundus photo of the left eye. It's very hazy, but I can see the optic nerve, and I know it's the left eye. Why is it hazy? Because there's dense vitritis. Vitritis is inflammation of the vitreous. Vitreous is a ball of gel, right? It makes up the back of the eye, and it should be clear, should be optically clear. But if it's full of inflammatory cells, it looks like this, looks like there's fog. Vitritis means inflammation, and that inflammation is either infective or it's non-infective, right? So it can be autoimmune, let's say, or it can be infective. In an immunosuppressed person, you need to be worried about infective vitritis. So this is typically what happens in a hospital setting, right? Person's immunosuppressed, or they've got long-term catheter, long-term IV access, they've got diabetes, they're old, they've got cancer, all those normal immunosuppressed kind of risk. HIV is the other big one, immunosuppressed risk factors, and then they develop blurry vision, or they say, oh, doctor, I can see floaters in my field of vision. Floaters can be a sign of inflammatory cells. They're literally seeing inflammatory cells float around. So that's urgent ophthalmology consult, because they may have an infection in the back of the eye. That's oral candida, right? So a person's got systemic candida, and you get secondary candida within the eye. Okay. Here's an image of, so these are composite images. So this is several fundus photos which are then stitched together. So you see more of the back of the eye. So where that round, that's where the optic nerve is. You can see it's swollen and there's blood around it. It's not a normal looking optic nerve. And then you've got all this yellow stuff emanating from the optic nerve. This is retinitis. Retinitis, inflammation or infection of the retina. That's what that looks like. Deep, confluent, yellow patches of retina. Diabetes and hypertension don't do this. Retinal vein occlusions don't do this. You don't get this confluent, yellow, big patches of retina. So this is a big concern for infection. And this is after treatment. So it doesn't look normal because this area looks kind of pale, but it looks a lot better than this. I think you agree. And so this is cytomegalovirus, CMV. Retinitis, which is the most common opportunistic infection in people with HIV. So once a CD4 count gets low enough, these guys need to be screened whether they've got symptoms or not. Because the CMV can be starting somewhere where it's not necessarily symptomatic. So in the hospital setting, those HIV patients need ophthalmic screening. Here's another image of herpetic retinitis. So CMV is in the herpes family, but so is herpes simplex, so is varicella. And again, look at this yellow confluent retinitis with, hemorrhage within it. There is blood there, but it doesn't look like diabetes. And again, the disc here is badly swollen. This person's going to have bad visual loss already. We want to stop them ever getting to this. So there's your risk factors, okay, for immunosuppression that I've mentioned. Bloaters, blurred vision, can be asymptomatic. And as far as ophthalmic signs, the white or yellow patches that we've discussed, optic nerve swelling and retinal blood, there's your sort of usual suspects. HSV and VZV, as far as the microbes go, are the most common, but all those other ones can cause, and there's more, but these are the most common ones. TB, ask about a history of travel overseas. There's an outbreak of syphilis in WA at the moment. I know of at least one case of syphilitic eye disease in the last several weeks. Candida aspergillus tend to be opportunistic, immunosuppressed hospital setting. Toxoplasmosis is also quite common. What's the management here? Well, as I've said, HIV patients, CD4 count under 200, they need routine screening, refer to ophthalmology. Then the management is systemic for the infection itself. So whatever the treatment of, syphilis, benzyl pen, and so on, ophthalmic treatment often is required. And so, for example, with herpetic conditions, we inject antiviral medication into the eye. And it's usually several injections over a period of days. So for CMV, it's most commonly we use ganciclovir. But there's other agents, foscarnet, that we can use as well. This is all urgent referral. The prognosis is very variable. This can be blinding, or, people can dodge a bullet, depending, like with everything in medicine, depends how early it's caught. The earlier, the better. Okay, so they're your opportunistic infections. Moving towards the end now, so we're going to move on to drug toxicity, okay? Here's a photo of the front part of the eye on a slit lamp. You'll see there's a hole here in the iris. Yeah, that doesn't belong there. The pupil doesn't look round. This is iris trauma. And if you're an ophthalmologist, immediately you'll guess, look, there's some blood here on the conj, probably a corneal wound here. This person's just had cataract surgery, and the iris has become damaged during the operation. A common cause of iris damage during cataract surgery is when you've got a male patient who's on prostate medication, okay? So that's what that first image is, and that damages the iris in ways that then affect cataract surgery. I'll explain that in a moment. Here's a picture of a cataract, and this particular type of cataract, actually affects the back of the lens. Now, it's hard to appreciate that on a two-dimensional photo, but if you were to look at this patient on a slit lamp, the front part of the lens would actually be clear, completely clear. Just the back of the lens has become hazy. So we call that a posterior subcapsular cataract. Posterior, back of the lens, subcapsular, it's just under the capsule. So the capsule is what holds the lens, and that part of the capsule at the back, posterior, becomes cloudy. So it's a type of cataract where only the back of the lens has become cloudy, not the front part. And this is typical for steroids. It's a common complication of systemic steroids or topical steroids if they're taking steroid drops for a long time. This can quickly knock off vision. So steroid medication can quite quickly damage vision in one or both eyes from rapid onset posterior subcapsular cataracts. So here's an image of a right fundus photo. You'll see that in the center of the macula there's a sort of a donut appearance, which shouldn't be there. Right? Looks like there's a pale donut there. This is called bullseye maculopathy. You know, a bullseye on a dartboard. Looks like there's a bullseye at the back of the eye. That doesn't belong there. That's not normal. So this is a complication of hydroxychloroquine, which is a immunosuppressant medication. Plaquenil is a trade name, often used in SLE and in rheumatoid arthritis. Okay, so those people need ophthalmic screening. And finally, you can see these little bands on the cornea, front part of the eye. Should be clear. It's not clear in this person. Got this quite pretty appearance on the cornea. So we call this vortex keratopathy. Because supposedly it's shaped like a vortex. Keratopathy means problem with the cornea. So this is a side effect of amioderone, long-term amioderone use. These are the 4 medications and the 4 side effects that I want you to be aware of, right? So tamsulosin, trade name is Flomax. There's probably other trade names that I don't know. Duodart is another one. So this is men with prostate disease. So your job here is, if there's a man with prostate disease and they need ophthalmic opinion, referral, cataract surgery, just mention that, you know, in your list of medications, and try and avoid tamsulosin, to be honest, if you can. Use an alternative agent. What it does to the iris is it makes it very floppy, right? So normal iris during cataract surgery will more or less stay where it's meant to stay. But in cataract surgery, if they've had tamsulosin, and even if it's been a short duration, it affects the iris so that A, it doesn't dilate like normal, and B, it becomes very floppy. I operated on a guy this morning with this, right? No iris trauma, I'm happy to say, but I went very slowly and carefully because I immediately recognized that he had this crappy, floppy iris, didn't dilate well. I can't really see what I'm doing as well as I normally can. And what happens when the iris is floppy is the iris actually flies out of your corneal wound. So it's so floppy that, you know, in an airplane cabin, if you open a door, everything gets sucked out. So when we do eye surgery, we're effectively creating a door in a pressurized system, right? The eye's a closed cabin, stick a hole in it. If things are floppy, they'll want to fly out. And so that's what happens with tamsulosin. Floppy iris wants to fly out of the wound. Now, I've got instruments in that wound. So naturally, if the iris is flying out and I'm manipulating with an instrument, my instrument's going to damage the iris. So that leads to basically a second pupil, which is going to cause this person glare and other visual problems. So ophthalmologists hate tamsulosin. They hate prostatic medications for that reason. Steroids. Look, if someone needs to be on steroids for more than a few days, then just get them seen by an optometrist or an ophthalmologist to make sure they're not developing a cataract. Definitely, if they need to be on long-term steroids, they need to see one of us. The cataract is easy enough to treat, but in a younger person with very early onset cataract, someone in their 20s, let's say, which does happen occasionally, there's lots of other considerations about, you know, how you do the cataract surgery. So flag that early if someone's going to be on steroids. With Plaquenil, everybody who's on Plaquenil needs to be seen by ophthalmology, at least for a baseline screening and assessment. Because Plaquenil can be toxic to the central macula, can damage central vision. So that's a automatic referral. Oh, you've been started on Plaquenil by your rheumatologist. Have you been referred to ophthalmology? Usually the answer is no. Make sure they get seen. And finally, amioderone. I mean, this is probably uncommon, but if someone's going to be on prolonged amioderone for some reason, long-term hospital stay, then get them screened at some point as well. If they're going to be on it for, let's say, months. then get them seen by ophthalmology. So here you go. Good, I'm glad I've got a picture of this. There's an iris flying out of the eye, right? This is a pain because this instrument, this surgeon's trying to reposition the iris now, push it back inside the eye. And of course, the iris is very soft tissue, so you're going to damage it in the process of sticking it back in. That's called iris prolapse. Here's just another picture of vortex keratopathy from amioderone use. So I've probably mentioned most of this stuff already, but how does it work? Steroids lead to remodeling of the capsule, okay, the back of the lens. Plaquenil and amioderone, you get direct deposition of the drug itself or byproducts of the drug. And tamsulosin, prostate medication, is antagonistic to the dilator muscle, to the receptors in the dilator muscle. So therefore the iris doesn't dilate properly. And that damage usually permanent. So short-term drug use and then permanent effect on the iris. How do they present? Steroids, you get cataracts, so blurry vision. Similar with amioderone, blurry vision. Amioderone can rarely cause optic neuropathy. So again, high dose, long-term, make sure they're seen early. Plaquenil, we see a bullseye. And so there's a threshold for plaquenil use where it's considered high dose. And that's if it's more than, this is gold star sort of stuff, but more than 6.5 milligrams per kilogram per day or 1,000 grams in total if someone's been on it for years, which they often are. And tamsulosin, well, hopefully we know before we operate, but if you don't, you'll see the floppy iris. Differential here is methanol. Differential really I'm referring to other drugs to be aware of. Ethambutol, which is used in TB, and tamoxifen. So if any of these medications or, illicit drugs, people need to be seen by ophthalmology. Management, refer everyone who's on plaquenil, steroids and amioderone. Try and limit steroids and amioderone and get them seen if they're going to be ongoing. And avoid tamsulosin if you can. Prognosis really depends on how long and the dose. So if someone's been on plaquenil at a high dose for long enough, eventually it's likely that they're going to get macular toxicity. These days it's less common, thankfully, because referrals are not too bad. That's the meat of the lecture over with. So just remember, you can see stuff inside the eye that you can't see in examination elsewhere. So make use of that. Don't forget diabetes. That's the single most important condition that we've covered. And just think about ocular manifestations when there's systemic disease. Hopefully we've checked off all of those things. And just want to say thanks for coming today. Best of luck and look forward to seeing you at your other sessions. Thanks.